Prof. Zamparo Lab, PhD student, Davide LATINI, they say, is right. Okay. Muscle and tendon mechanical adaptation across menstrual cycle and the influence of oral contraceptive. The stage is yours. Go ahead.
Good afternoon, everyone. Thank you for the introduction, Gaspare. Today I'm going to present some data about my PhD project about the potential effect of female sex hormones on muscle tendon mechanics. And I'd like to start with a brief introduction about the menstrual cycle. In a amenorrheic woman, the menstrual cycle is characterized by hormonal fluctuations that basically define three main phases: follicular phase with low hormone levels, ovulation phase with a peak in the periovulatory phase of estrogen, and luteal phase with a peak in estrogen and progesterone. On the other hand, there are some women that take oral contraceptive, which contains synthetic hormones to basically maintain the hormone level without estrogen or progesterone peaks. Estrogen and progesterone regulate different biological processes inside our body, mostly due to the presence of receptors inside human tissues, such as the musculoskeletal tissues. And as you can see from this slide, for example, estrogen is basically impact a lot of different processes inside collagen tissues, such as ligaments and tendons. And from the literature, we know that a raising in estrogen concentrations could basically affect or impact or cause microstructural changes inside this tissue. So now the question is, could this microstructural change could impact in vivo properties? So due to the importance of muscle tendon mechanics on human movement and the potential relationship with hormone levels, several studies have been conducted, and we decided to collect data about muscle tendon mechanics across menstrual cycle phases and oral contraceptive uses and not, comparing different tissues with different elastic properties, so from the stiffer patellar tendon to the muscle, and also with different plasticity capacity, with the hypothesis that probably there could be a greater effect of this hormonal fluctuation or more compliant tissues, and to also detect the differences between changes in hormones due to the assumption or not of oral contraceptives. To do so, we recruited 35 participants, divided into two groups, the no-pill group and the pill group. As you can see from this slide, the groups were matched for physical activity, anthropometric data, and also muscle strength and architecture, rest. The two test sessions were, the test sessions were two for no oral contraceptive users in follicular and luteal phase. And we detected the phases with an auto-tracking calendar-based method at the beginning, confirmed with blood samples, analyzed with the gold standard method, which is the spectroscopy. For the oral contraceptive users, the tests were during basically active pill phase, and just for a subsample of 6 participants, we repeated the test to confirm the differences in hormonal profile and mechanical parameters. Then, we collected data about resting muscle architecture, and then the participant executed isometrical maximal voluntary contraction in knee extension, flexion, and ankle plantar and dorsiflexion in a ramping mode, so 3 seconds to increase the external force values to reach a steady state and then relax. We collected with ultrasound apparatus fascicle and tendon behavior synchronized with external force expressed. Then we obtained tendon elongation. During the analysis, we obtained tendon elongation, belly shortening, and external torque to basically obtain torque deformation relationship. In this slide, you can see an example of torque Achilles tendon elongation of 2 participants, one intramenstrual cycle phases and the other taking oral contraceptive, and then calculated the stiffness as the slope of these curves in 5 different torque intervals. For the blood sample results, basically you can clearly see differences in hormonal profiles between the 2 groups, and also a correct detection of menstrual cycle phases due to the extreme differences in concentrations of estradiol and progesterone. About muscle torque data, there were no differences between phases and contraceptive users and not. Same for the deformation of tissue, so maximal elongation of the tendons and belly shortening. For tendon stiffness related to the torque intervals, we found basically no effect of menstrual cycle phases on patellar tendon stiffness. And for the Achilles tendon, so the more compliant tendon between the two, we found an almost significant intensity per phase interaction with a tendency in lower stiffness during follicular phase compared to luteal phase. Luteal phase compared to follicular, which was a bit in the direction of our hypothesis, also if it is not significant. However, the muscle, that basically is the more plastic tissue in adaptation capacity and also a bit like with level of stiffness lower, we found no differences. So, to sum up, basically, hormonal fluctuation during menstrual cycle could impact, but with a very small, slightly, let's say, Achilles tendon in vivo properties, mechanical properties, but these small changes doesn't impact the external, the mechanical output, such as like maximal torque production. Despite basically, there is also no effect of oral contraceptives, so the lowering of estrogen levels, endogenous estrogen level doesn't have an impact on these characteristics. And due to this, in a practical way, we can see that if there is a higher injury risk in some menstrual cycle phases, this is not related to changes on mechanical, muscle tendon mechanical properties related to hormonal fluctuations. And to further investigate the relationship between muscle mechanics and hormonal fluctuations and oral contraceptive pill use, we collected also data about explosive contractions, so to obtain values of rate of torque development and also muscle shape change during these contractions. And also we collected data about quantitative ultrasound technique, so radio frequency technique, on different tissues such as knee cartilage and also muscle and tendons. So thank you so much for your attention, and I would like also to thank my research group.
Well done, Davide, also for the timing. Thank you so much. Questions? Not this time. Not this time. Yeah, but I was coming slowly because it's the afternoon. I'm tired.
Thanks for the very nice talk. I just have a comment about, I've heard it a few times, trending towards significance. It could also be trending away from significance, and you can't possibly say which direction it will go. So just be careful on the terminology.
Thank you.
Ciao Davide, thanks for the talk, nice. I just have a question regarding, I saw a graph, maybe it was, as I'm pretty blind, maybe I saw wrong, regarding the torque they produce. I saw they were pretty low torque, like about 20 to 30 Newton meter, which is...
Which one?
One of the first one you mentioned, knee extensor, and that's pretty low, so I don't know if you miss a zero on the graph. Just if you can comment, because 20 Newton meter is pretty low torque. Further back, a few slides back. Yeah, for example, also there. I guess was the first graph. Just to know, maybe you can check the numbers later.
This one, so 30 Newton meter. No, I don't think so. All the points are above 50 Newton meters. So
We can chat later.
okay.
I think that neither Paolo understands what he asked. Yep. The group that was taking the pill, for how long had they been on therapy?
Minimum 6 months.
6 months. Okay. I mean, I'm interested in the results, but I'm somewhat surprised because estrogens have been shown to have an effect on collagen synthesis. And I think some papers also found some effect on tendon properties. I think they...
Actually, in vivo mechanical parameters, no. The patellar for sure, and also the patellar, also the adaptation capacity of the patellar tendon is not impacted by oral contraceptive use. We expected something about the muscle due to probably a more plastic capacity, but also in the muscle there is nothing about this. Yes, the oral contraceptive use basically reduce collagen fractional synthesis rate due to IGF-1 action, but basically probably this is not too much to affect in vivo properties. And another very beautiful thing is that for now there is probably, it could be also due to this, there is no study about the possible impact of oral contraceptive use, for example, on the degradation process on the collagen. So probably there is no matching between the two the two things. That's why probably.
So, good news. Thank you.
Thank you.
Thank you very much.
Thank you.
That's very